Tumor necrosis factor. Pro-inflammatory cytokines produced by the macrophages activate macrophages and neutrophils, co-modulated T cells, key mediated in the gram-negative septicemia, stimulate interleukin 1 and anti-tumor effect. So humoral immunity, it is through B lymphocytes stimulate plasma cells to secrete immunoglobulins having light chains K and delta, heavy chains mu, delta, lambda, E. Antibodies plus antigen, they cause lysis of bacteria and neutralize toxins. Antibodies dependent cell mediated immunity. Plasma cells in lymph nodes, bone marrow and spleen. What are the different types of antibodies or immunoglobulins? These are called as Ig, GAMED. IgG immunoglobulin are most abundant, 70 to 80% intra and extravascular space. Longest half-life is 21 days. IgA, all secretions, body surface, mucous membranes. IgM, first line of defense, beta lymphocyte restrict to plasma. It is limited to plasma. IgE, very small amount, mast cell, antihistaminic action. Then IgD, very small beta cell activation. Cell-mediated immunities. This we have seen humoral type of immunity through antibodies. Cell-mediated immunity is through T lymphocytes and humoral was through B lymphocytes. Cell-mediated antigen specific T cell receptors, membrane bound, made up of two pairs of polypeptide chains, TCR1 and 2, gamma and delta, alpha and beta, TCR2, alpha and beta. Leukocytes are different by their cell surface molecule known as cluster of differentiation. Most time you see CD, cluster of differentiation. These are identified monoclonal antibodies. T lymphocytes, helper, CD4 and CD8. CD4 are helper T cells and CD8 are cytotoxic. They kill the cells. What is major histocompatibility complex antigen? MHC. Gene coding all surface glycoproteins. Major play fundamental role in immune response, presenting antigen peptides to T cells. Process of dual recognition of polypeptide plus MSC restriction. MSC gene short term of chromosome 6. Chromosome 6 important. These are the classes of major MSC gene. Class 1 A, B, C. Present in nucleated cell, they signal to cytotoxic T cells A, B, C. Class 2 are DP, DQ, DR. Beta cells, B cells, B lymphocytes activated T cells, macrophages signal to T helper cells. So this T cells are of two types, cytotoxic and T helper. So class 1 cytotoxic T cells and class 2 signal to T helper cells. Class 3 components of complement system, endogenous antigens. Exogenous antigens are CD4 plus T cells. HLA subtypes are important in determining matching in transplantation. During transplantation, we do HLA matching. Lymphocyte cells originate from stem cells. Lymphocyte cells destined to become T cells from bone marrow migrate to thymus. Primary lymphoid organs are thymus and bone marrow. Secondary lymphoid organs, lymph nodes, spleen and malt. HLA antigen diseases. What are the diseases which is related to HLA? We have seen HLA A, class 1 A, B, C. So this is B, DR, DQ, DP. To B27, Heritage disease ankylosing spondylosis. DR, DQ, DP. DR2, DR3, DR4. Good pasture syndrome. DR3 is Hashimoto's Addison's disease. So these are antigen related. We'll go for lymph node, major histopathology complex, HLA antigen disease, ankylosing spondylosis disease, good pasture syndrome. How is the lymph node? Afferent lymphatics, they come from side. afferent lymphatics. Now there is the cortex, primary follicles, afferent lymphatic, and you see these are the secondary follicles, and these are the efferent lymphatics and vessels. Now we will see mucosa associated lymphoid tissue, mucosa, MALT. Mucosa associated lymphoid tissue, immunoglobulins to luminal surfaces. All the mucosa, three components in the gut. Stomach, this small intestine, the gut has got the mucosa and has got three components. These are pairs, patches, small intestine, lamina propria, T helper cells, intraepithelial cell, T suppressor cells. Now let us see what is the immune response. Antigen they produce. How the immune response is produced? Antigens. Lymphocytes, antigen presenting cells are dendritic cell, macrophages, beta cells. Antigen presentation: direct, unprocessed donor, indirect, processed. T helper cells, T helper 1, T helper 2, tumor necrosis factor, interferon Y, cellular immunity. Tumor T helper 2, interleukin 4, 5, 10, antibodies by the beta cells. Complements are the protein that act as the enzymatic cascade activated by antigen antibody complex. Antigen antibody complex, they activate the complement. Bacterial surface is alternate. There are two pathways: classical pathway and alternate pathway. Antigen antibody, if it is classical, and bacterial surface alternate pathway. Functions: they cause membrane lysis, kill bacteria and target cell, opsonization, phagocytosis, remove immune complexes, mediate acute inflammation via vascular and cellular. So classical pathway and alternate pathway, antigen antibody, alternate pathway, bacterial surface antigen, C3 convertase. C3 is converted through C3 into C5a, C3a, activated C3 cause inflammation, increase vascular, cellular, opsonization B, and cell lysis. These are the three methods: cell lysis, opsonization, and inflammation. Immune deficiency. If there is deficiency immunity, they are classified as specific and non-specific, primary and unprimary and secondary. Intrinsic defect in immune system is genetic. Then if there is antibody related bacteria, when staphylococcus, if there is cellular immunity deficiency in cellular immunity, then viruses, cytomegalovirus, herpes zoster, papillomavirus, fungal infections are caused, protozoa, bacteria. If there is non-specific deficiency, complement, pyogenic bacteria, and phagocytosis, neutrophil staph infections are caused whenever there is deficiency. Hypersensitive reactions, the body response is high. That is, the mnemonic is acids, altered immunological response to severe and harmful reaction to extrinsic antigen. There are 4 types represented by A, 1, 2, 3, 4, and 5th also. The first type 1 hypersensitivity, it is A is anaphylaxis. Acids is mnemonic. Anaphylaxis, it is mostly commonly caused by allergy, and immediate mast cells and basophils are responsible. Second type of is antibody to cell-bound antigen. These are cytotoxic. The third type is immune complex reaction. And fourth type is delayed hypersensitive reaction. Delayed hypersensitivity T cells. And fifth is stimulatory. Now what is this acid and egg T? Type 1, 2, 3, 4. ACID. Anaphylaxis is 1, cell bond is 2, immune complex is 3, delayed is 4. And EGGT, it is the mnemonic to remember: anaphylaxis, hemoglobin E, anaphylaxis caused by E, allergy, and cell bond again IgG, and cell bond is G, immune complex is G, and T is delayed hypersensitivity T types. Now type 1 hypersensitivity, anaphylaxis. Anaphylaxis to any of this, this immediate treatment is intramuscular adrenaline 1 in 1000. This mast cells and basophils, this increase IgE type of immunoglobulins that releases causes vasoactive substances, histamine, chemokines. If there is shock, most of the time bee sting, wasp venom, antibiotics, peanuts, any allergy, which we call it is type 1 hypersensitivity. Individual producing excessive reaction to antigen, then hypoatopic. Type 2, it is cell bound, antigen antibody, antigen antibody complex, IgM or IgG, plus antigen on cell surface, cell death via lysis, phagocytis. Examples are most of the blood transfusion reactions, Rh incompatibility, autoimmune hemolytic diseases. These autoimmune hemolytic diseases, ITP, myasthenia, for this Coombs test is done when there is blood transfusion reaction, when there is lot of hemolysis, that is direct Coombs test. Myasthenia, good pasture syndrome. And type 3, deposition formation of immune complexes. Immune complex free antigen antibody, IgGM, IgA. Tissue destruction from lysosomal enzymes, platelet aggregation. Examples of type 3 is serum sickness, drug-induced hemolytic anemia, microbial antigens, post streptoglomerulonephritis, rheumatoid. These are the type 3. Type 4 hypersensitivity is cell mediated and delayed hypersensitivity. Lymphokines reaction takes 2 to 3 days to develop. Examples like tuberculosis, viruses, fungi, tuberculin. Type 5 stimulated type of Graves' disease. An example of type 5. Now this is the classical pathway, alternate pathway. C is converted to 3, opsonization on this. Immunodeficiencies, specific, non-specific. Hypersensitive reaction type 1, 2, 3, 4. This 2 is commonly most important blood transfusion reactions and Rh incompatibility. Type 4, mechanism of autoimmunity. Now we'll see autoimmunity. What is the mechanism of autoimmunity? Auto means self. Immunity is against destruction of cell. It can be genetic, it can be antigenic, dysregulation. Examples, organ specific autoantibodies, thyroid antibodies, thyroglobulin Z, Hashimoto's thyroid, Graves' disease, THS receptors, pernicious anemia, parietal cells, autoimmunity, good pastures, glomerulus and lungs, basement membrane, myasthenia gravis, ACH receptors, non-organ specific, systemic lupus erythematosus, nuclear antigen DNA smooth muscles, rheumatoid arthritis, IgF, scleroderma. These are non-specific. Now let's have some regarding the auto organ transplantation. So what are the different types of grafts? Autograft, isograph, allograft, xenograft. Autograft, skin grafting, which we do, is the autograft from one surface part to the other. Isograph, genetic identical twins. They very rarely again the twins, monozygotic twins, same type of allograft is commonly done. Then renal transplantations, species are same, genetic may be dissimilar. Xenograft, different species. What are the graft rejection? How does the graft rejection occur? There are 4 types: hyperacute, acute and chronic. Actually acute has got accelerated and acute. Hyperacute is rare nowadays because HLA typing and blood typing is done. It occurs immediately during minutes or hours. During surgery only, kidney gets cyanotic, flaccid and thrombosed and it is lost. ABO incompatibility, this is the main reason for main incompatibility. Preform antibodies, major history complex antigen in the donor, activation of complement gets activated, polymorph, platelet aggregation, obstruction to the blood vessels leads to ischemia. Accelerated within 2 to 4 days. Acute type of. So this is the regarding graft rejection. There are 4 types. So acute type of graft rejection, it occurs because of cell mediated and antibody mediated. Commonly it's very common and it is treatable condition. 1 week to 3 months post transplantation. Commonest is 7 to 10 days. Patients have severe episodes of acute several episodes of acute rejection in first 3 months post transplant. Early diagnosis is essential to prevent organ damage. Histology is CM rejection of the shows infiltration of tubules and interstitium with cytotoxic T cells. It is antibody mediated, detected donor specific in recipient blood. Kidney histology shows intimal arteritis, thrombosis of blood vessels, C4D in peritoneum. Chronic slow loss of organ function, months to years. Kidney hypertension, proteinuria histology is glomerular membrane is thickened, glomeruli is hyalinized, intima is hyperplasia, tubules atrophied. Factors, these are immunological, non and non-treatable. Delayed reaction is non-treatable. Now, immune suppression. How you do the immune suppression and to prevent the graft rejection? Prevention is done by good matching donor and recipient, that is HLA matching. Suppress the immune system. Immune suppressor drugs are before transplantation. Induction is done before transplantation. Early post transplant. Avoid delayed acute reaction. Anti-interleukin 2 monoclonal antibodies, basilumab and daclizumab. Maintenance steroids, anti-1 rejection treatment. Cell-mediated acute rejection, IV steroids, methylprednisolone, steroid-resistant cell-mediated rejection, anti-thymocyte globulin, antibody-mediated acute reaction, plasmapheresis to remove the antibodies, IV immunoglobulins to neutralize circulating antibodies. Immunosuppressive drugs are most of the time the mainstays. Corticosteroids interfere with antigen presentation, inhibition of T cell activation, it block IL-1, 2, 6, interferon, anti-inflammatory, neutrophils. Antiprofit drugs azathioprine interfere with nucleic acid, affect cells that actively replicate T cells. MMC and MPS inhibit enzyme pathway of purine synthesis. Calcium urine inhibitors, cyclosporine, tacrolimus inhibit T cell activation through IL-2 gene transcription, prevent generation of cytotoxic T lymphocytes. Sirolimus macrolide antibiotic, rapamycin, mTOR, mammalian rapamycin antibiotic. Cytokine dependent T cell proliferation, anti-lymphocyte globulin, anti-thymocyte globulin, ATG and ALG, steroid resistance. Monoclonal antibodies, these are anti-CD3, OKT, anti-IL-6 against CD3 complex of T cell receptor blockage killer cells. Anti-IL-2, bacillus, tacrolimus. Side effects: immune suppression, infections, opportunistic infection, bacteria, tuberculosis, urinary tract infections, viral infections like cytomegalovirus, hepatitis, BK viruses, fungal infections, aspergillus, pneumocystis pyogenes, neoplasia, which are caused skin cell carcinoma, squamous cell carcinoma, post-transplant lymphoproliferative disorder, beta cell lymphoma, sarcoma. Graft versus host defense. Host immunocompromised, receives immunocomplement lymphocytes, bone marrow transplants, immunocomplement cells recognize host as a foreigner. Fever, weight loss, and hepatosplenomegaly. So these are some of the drug: calcineurin, infection, neoplasia.